I'm going to talk about the frontal plane today. And the frontal plane has been on my mind probably because I have been working with a couple patho-PEC people. So if you want to know what a patho-PEC, pathological PEC pattern, I did a video on it maybe last week or a week and a half, 2 weeks ago. And I'll just quickly go over it. In the beginning, you have this left AIC pattern. Left side of the pelvis comes forward, right side goes back, and it orients the entire pelvis to the right. That's the typical left AIC pattern. That is what we would say is ingrained in all of us. We're born with a tendency to favor the right side. Again, it goes back to the fact that we have more muscle on that right side. The bigger right diaphragm loves to pull our lumbar spine to the right. We lose the left hamstring on the left, we lose the obliques on the left, and we just end up a little bit too much to the right. That's that left AIC pattern, so we're just always weaker on the left side, and you just see this over and over and over again. The left side is just weaker than the right. That's the typical pattern, and in this typical pattern, here's my femur. Let me just fix this. This femur, if it goes with the pelvis, it would face this way, towards the right. So the left leg has to abduct a little bit and externally rotate to stay straight. The right femur adducts and internally rotates to stay straight. So we have a situation where the pelvis is forward on the left, back on the right, and oriented to the right with a right leg that's adducted, ADD, and a left leg that is abducted. Now, they are being positioned into that state. So they are not actively abducting. So the left leg is not actively abducting in terms of meaningful, purposeful movement. It's being forced into that position to stay straight, and the right leg is being forced into a state of adduction. So the interesting thing is, just because the left leg is in a state of abduction doesn't mean it's actually good at abduction. We concentrate on adduction, adduction. So abduction and adduction are the frontal plane. It enables us to side bend, move our arms like this, and the legs out to the side and back in. So this is the frontal plane. It divides the forward, the front half of you to the back and the back half. So even though the left leg is in a state of abduction in order to stay straight, it's not actually, your brain is not abducting purposefully because it's already there. So we generally, in the beginning at least, we concentrate on getting internal adduction, and internal rotation of the left leg as we orient the pelvis to the left, because that's what has to happen for us to be on our left leg. But then we have to get off our left leg effectively, and that's going to require abduction. So first we focus on adduction and internal rotation as we orient the pelvis to the left. That's the hip shift. That's bringing the right side forward and left side back. That's almost the majority of exercises have you doing that. And then once we're there, we have to stabilize in that position as we rotate our upper body to the right. And then we have to push through and then abduct to push us back to the right side. So that does require left glute and left glute medius to push us to the left. So you need adduction, frontal plane adduction, to get us back into the right position. And then you also have to teach yourself, or have someone teach you, to abduct also. So it's not only adduction that the left side needs. It hasn't done it in a very long time, and it desperately needs it, and that's where you focus most of your time. But then once you're there, adduction, here's the left stance, we're good. You then need to stabilize there, and then push to the right effectively using your left glute instead of extending your back and just falling to the right. You need an effective push to the right side. On the right side, because the right leg is in a state of adduction, so our pelvis is to the right, and we are balancing in a state of adduction on that right leg, so you'll often have a tight right inner thigh or tight right adductor. We focus on using abduction through the glute medius and the glute max, so that we can push effectively through our big toe and orient our pelvis to the left and shift our weight to the left. Because we've been stuck in adduction for so long on the right side, and we've been stuck with our pelvis to the right for so long that we just stay there. This thing never abducts and never pushes us completely to the left side. So that is that left AIC pattern. But even though we have to work on abduction mostly and external rotation of that right leg, you also need to be able to have that right leg adduct while being controlled by the right glute. So you lose abduction, which is what you work on first, but just because you're in an adducted state doesn't mean you're adducting properly, because your right adductor will probably be overactive, but you've lost your right glute, and you've lost probably your right glute medius posteriorly. Your hip flexor on the right side is probably not working properly because it's an external rotator, but because you never externally rotate, it's probably weakened. So a lot of times you need to get that right psoas back in the game, and you have to be able to train adduction while still using that right glute to control that adduction instead of just everything falling in without control. And that's the issue. So there's different progressions in the PRI in the hierarchy of rebuilding this pelvis for adduction and abduction on both sides. Again, a lot of times the last two movements, the movement of adduction being controlled by the right glute, which is what we need, is secondary to abduction. Once abduction is working, quite often that second part, the adduction, proper adduction being maintained by or being controlled by that right glute, and appropriate right adductor activity, that kind of just usually just kind of falls in place without having to work too hard on it. Same thing on the left. We have to work a lot harder on adduction of the left leg. Abduction often just starts to work, just kind of goes back to where it should be, but not always. So people need to be able to adduct and abduct on the left appropriately, and they need to also abduct on the right and adduct on the left appropriately, and that's what it's all about. Because once your pelvis is in a pattern, none of these functions are working necessarily appropriately. You might be doing them one way or another, but in order to accomplish this frontal plane shifting, because the pelvis is stuck, you have to cheat to do it. And usually the cheating occurs through rotation through the SI joints, which is not where you want it, or through your lumbar spine, which is not where you want it. It should be happening up through your mid-spine. So when you cannot abduct and adduct equally on both sides, because it's not hard to equalize the range of motion. That's pretty simple. Once you reposition the pelvis, these ranges of motion, internal rotation, external rotation, abduction, adduction, they generally don't need much help after that to really equalize that range of motion. But you need to be able to dynamically, neurologically, neuromuscularly control those movements with the proper muscles. Just because you've repositioned, just because your pelvis is now neutral and you have these ranges of motion, doesn't mean you can actually utilize these new ranges of motion effectively and under control. And in that sense, well, in that situation, you're probably just going to go back to old compensatory movements. And that brings me to patho-PECs again. Patho-PECs are forward on both sides, so their legs end up externally rotating and abducting on both sides. So their legs are like out and out. They have, and this was in my notes and I just wrote it down, I guess from one of my manuals. QLs are overactive because they have no butt. ER'd, externally rotated femurs. Patho, they have no neuromuscular control of that pelvis. Their muscles are all off. Nothing is working properly. they're moving, but it's completely cheating. They're completely compensatory, and what they feel is just tension, lower back tension, mid back tension, neck tension, foot issues, every issue. They are just tense, just constant tension. They have to literally rebuild their pelvis, starting with hamstrings, obliques to bring the rib cage back down, internal obliques, external obliques, left and right side, and adductors on both legs to bring those legs in and straighten them out so they can regain control of this pelvis. And once they have control of this pelvis, then they have to learn to shift back and forth appropriately. So it takes, people were asking why do patho-PECs take longer? It's because they have no control over this pelvis. It's just there. And the only way they control it is through increased back tension. That's pretty much what's controlling their pelvis. They're cheating on every movement. They have to use compensatory muscle function, hip flexors. Everything is compensatory. Necks are always overactive. And again, one of the patho-PECs I worked with recently, after we had our second session, I saw her again for the third session, and her neck that was so tight. She told me, she's like, oh, I feel my hamstrings now. That was great. And then I tested her, and that neck was so relaxed. So just by getting that better connection through her heels, because she had to get better shoes, heels, hamstrings, because when she would walk around without shoes on, without sneakers on, her tests would go back to the way they were previously, to a positive test, which means she couldn't adduct. But when she then put her shoes on and I just had her walk around the room, I retested her and she went neutral again. So she realized that she needed to wear sneakers more often, that has strong heel cup. She worked on the hamstrings, and she said, I worked on the hamstrings, and lo and behold, or not so lo and behold, not that I was surprised, but her neck was so relaxed, whereas before, the week before, it was tight. That thing was not going to move. She didn't have a neck problem. Her neck will be fine, but she has to neuromuscularly control this pelvis. Otherwise, that neck can't relax, because she's using her neck to stabilize her whole body, and she's using hip flexors and lower back to stabilize her whole pelvis. And when that's happening, you have to cheat. You have to move in compensatory patterns. And the more compensatory you are, and a PEC or a patho-PEC is going to be very compensatory. The more compensatory activity you have, the more autonomic sympathetic nervous system tension skyrockets. You feel like crap. Your whole body feels like crap. I've been there. And you're cheating on everything. So yeah, nothing's working properly. So it takes longer. The more compensatory activity has been going on, the longer it takes to get this frontal plane back, to control the pelvis, so you can move side to side without having to cheat in order to rotate as you go side to side. Because rotation, if you cannot go side to side with the proper muscles, you're going to, and that means you can't rotate through your mid-spine, through where it should happen, through here, but on the back, right? You're going to go through your lumbar spine, and that's going to be SI joint dysfunction city. All right? So again, this just kind of all comes back together. Patho-PECs, left AICs, doesn't matter. The frontal plane is what you have to control. And even though you work more on the right side in abduction and more on the left side in adduction, adduction, so this, left leg in, right leg out, that's really what you're working. Adductors and right glute. You still need to be able to do the opposite also, because if you're stuck in that position, if you're stuck in a state of adduction on the right side, it doesn't mean you're actively adducting properly. So just because you're stuck in a position doesn't mean you're actually doing it. Just like if you're extended, if your back is extended, it doesn't mean you actually know how to extend. So just a quick word, or actually that was not quick, that's gone up to 14 minutes. However, that will make more sense to people who are doing PRI, and I guess that was what this video is more for, were people who are doing PRI and are trying to bring all these subjects or these various concepts together.